Good afternoon, everyone, and welcome to today's program. It's titled Concurrent Documentation, The Time is Now. I'm Dennis Grantham, Editor-in-Chief of Behavioral Healthcare Magazine. Today's program has been sponsored by the Echo Group. Many thanks, of course, to our sponsor, the Echo Group, and to all of you in our audience for giving us your time and attention. Before we get started, let me just run through a few quick housekeeping details. Note that each window on your screen can be moved by clicking it and dragging it, or enlarged or minimized by clicking the icons in the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time. And if you cannot see the Q&A area at this time, simply click the red Q&A button at the bottom of your screen. To download a copy of today's slides, please click the link in the Resources area at the bottom left of your screen. If you have any technical issues at all during the program, please click the yellow Help button so we can get somebody to troubleshoot the issue with you. For all of you who are seeking CE credit, repeat, for CE credit, we will distribute certificates via the green CE certificate button at the end of today's program. So, if you need CE, wait at the end of the program for final instructions on exactly how to get those. You can also tweet during today's presentation via the Twitter widget by clicking on the blue Twitter icon at the bottom of your screen. Simply click Post and Authorize to log into your Twitter account and begin sharing at the hashtag #BHDocumentation, or should I say hashtag BHDocumentation. At this time, it's my pleasure to introduce both of our speakers, Jim Wilkerson and Joe Vigier. Jim Wilkerson is Director of Quality Management and Outcome Evaluation at the Mental Health Centers of Central Illinois, a private, not-for-profit provider of behavioral health services that serves about 10,000 individuals from multiple locations in 6 counties. These counties include the cities of Springfield, Lincoln, and Jacksonville, Illinois. Joe Vigier is currently the Vice President of Business Development at the Echo Group. He joined the company in 1999 and has held a variety of positions as a consultant, as leader of the professional services team, and in operations management. He has a diverse behavioral health background, including case management, managing residential systems, and working with community-based treatment teams. So both of our speakers are well qualified to speak with you today. Thank you to them, and again to you for taking time. With that, let me introduce you to our speakers. Joe, are you going to go first?
I am, Dennis. Thank you very much. Good afternoon, everyone, and thanks for joining us. This is Joe, and I work for the Echo Group, obviously, and Echo is a leading vendor of electronic health records, billing systems, reporting tools, and revenue cycle management solutions for behavioral health. We offer locally hosted and cloud-based solutions to all sorts of behavioral health organizations in over 30 states from our 4 offices around the country, and we're very pleased to be able to offer this webinar today with Jim Wilkerson on concurrent documentation. Jim's organization, Mental Health Centers of Central Illinois, has been a customer of ours for many years. They're an excellent example of what can be done to improve operations, the bottom line, and clinical care using our electronic health record and billing software. Jim will be sharing with us his experience on a topic that I've seen bounce around the behavioral health world for quite a while now, concurrent documentation. We've seen it on conference agendas for a long time, and it seems to be elusive for many organizations. We've subtitled the presentation, "The Time is Now," because we truly believe it is. One reason is the changes we're seeing in CPT coding standards. If you've taken a look at those and started to dig in, you've seen some pretty radical changes, particularly around things like E&M codes and the noting requirements that are related, that really speak to documentation being done in the session. We have a lot of attendees today, and I think that also speaks to the popularity of this topic. We also have done a white paper recently on this very topic, which you might have noticed. And if you haven't seen it, check out Behavioral Healthcare Magazine's website for that document in their white paper section. Additionally, electronic health records like Echo's visual health record really have become more of an interactive tool in providing services to clients while showing that screen to folks without disclosing other protected health information from other clients, and using that as a tool to make concurrent documentation something less mysterious and intrusive, and really something that drives and demonstrates collaborative care that's client-centered. So it's our hope that today you take away all sorts of practical advice that can give you new insights to make this work for you. And we do believe the time is now to improve the quality of care for your clients, enhance reimbursement, and provide staff a different kind of quality of life at work. So I'm going to help tell you a little bit about mental health centers, and then we'll hand it over to Jim to move forward with today's session. So Mental Health Centers of Central Illinois, or MHCCI as we affectionately call them, is a private nonprofit providing comprehensive behavioral health in the Springfield area. They've been doing this for 65 years as an affiliate of the local Memorial Health System. MHCCI is accredited by CARF and has 7 sites in 6 counties, as Dennis mentioned, and it last year served over 9,000 clients. They're a progressive health information technology organization. They've been an ECHO customer since 1998. They've instituted concurrent documentation at their organization since 2009, and they've been using our product for electronic charting since 2002, and our most recent version, the visual health record, since 2010. Jim has been a really wonderful resource to us in helping us better understand the great work they do, and sharing that with our customer base and now with the behavioral health community at large. He's presented at our national user group called the Peer-to-Peer Conference a couple of times now, and their organization has often been a beta tester for us, and we're really thankful for their willingness to share and be part of a community with us. So with that, I'm going to turn it over to Jim Wilkerson, and he can talk to you a bit about some of the good work they've done with concurrent documentation.
Well, thank you, Joe. I appreciate that introduction, and I have to say we're really excited about being able to present on concurrent documentation and taking a look at how you can tweak your EHRs to help them better support concurrent documentation as we go forward in the future. Because really, from my perspective, and I think, Joe, you mentioned this, that it's really the future of what's going to be happening with healthcare, with mental health care as we move forward. There are paper-based systems out there. You can technically do concurrent documentation under a paper-based system, but the reality is when you want to increase efficiencies, when you want to take a look at the structure, when you want to make sure that you're getting the best possible services for your staff members and for the individuals that they serve, you have to have an EHR that is set up, that is structured to provide those services and to be able to do the documentation in a fast and friendly manner, and with a structure that, again, is set up and is able to take concurrent documentation and move that forward. So having said that, we have our agenda here of the items that we're going to be looking at, and we're going to go run through what is concurrent documentation, what does it really mean, why we should use it, and the benefits from the different areas of staff, client, and the agency, our implementation plan, how we did things and rolled it out to our staff and rolled it out to the individuals that we serve. And within that, the staff training, office setup, some of the form revision pieces that we took a look at, and to really kind of give you an idea of what's going on, and then looked at the lessons learned in Q&A. Now, there's always the question I usually get to say that, well, everyone that's on the phone has an idea of what it is or, understands the benefits, so why would we go through those? And I just want to make a point to say that if you download this later, the presentation that we're using here is the actual training that we utilize when we interact with our staff and we train the new staff that are coming on board. Naturally, we've tweaked it a little bit for the folks that are going to be that we're doing our presentation for today, but still this would give you a good start in terms of being able to grab onto concurrent documentation and bring it into your organization. And part of that is really emphasizing the benefits to the staff members and to the clients. I'll talk about that when we get to the lesson learned, but just to give you a little bit of an update there and just kind of let you know what I'm thinking, that is kind of a critical pathway to make sure that when you're doing your training and you're rolling it out, that you address those two different pieces there. So having said that, what is concurrent documentation? What are we talking about? And you may have also heard it called collaborative documentation. They're the same general concepts that are out there. But the main thing is that you're doing your documentation in cooperation with the person that's served. So it's not just a matter of you sitting at the computer and typing in what you thought and what you saw and what was occurring and saying, hey, just give me a second, you can tweet or you can do whatever you're doing over there. When I'm done with this, then we'll get back together. That's not really what we're looking at here. What we're looking at is a structure where the two of you together are documenting what occurred in that particular session. And so there are some issues, as we'll talk about here in a minute, with staff members being a little bit uncomfortable with the person served being able to see what you're saying about them. But that's an issue that you can, through training and through the interactions that you have with the individual served, you can kind of overcome those pieces. And really it's just a matter of making sure that your staff understand the importance and being able to move forward with that. So again, one of the key pieces, that cooperation of the person served. And it's done during the service naturally for your assessments and your service planning or treatment planning, as we call it, because those items usually are so big that you're going to have to do it as you're going along and as you're going through that part and going through those different forms. When you're doing a standard service of therapy or case management, then we usually move it towards the end whenever you're documenting your progress notes. So most of us are trained from a therapy perspective that you use the last 5 to 10 minutes to do a summary of what occurred during that session and just kind of have that discussion with the individual to say, this is what I saw, this is what I thought we worked on, possibly hand out some homework for the next time, that type of thing. And we're using that timeline to go through and do our documentation. So that's kind of what it is in a nutshell. Again, it is collaborative. It's working with the person and bringing them into that discussion and bringing them into what's happening and helping them to engage further with the services and with what's being provided. So why should we use it? We all know we're in the mental health or in healthcare. We understand the concept of heavy documentation. We have a lot of paperwork that we have to do for individual states, for federal mandates. If you have grants, sometimes you have grants that have extra pieces that they want to see or things that you have to create. So with that heavy documentation load, we have to make sure that we have time built somewhere so that we can go ahead and do that documentation. Now, traditionally, that's been outside of the service. So you provide an hour's worth of therapy or an interaction with an individual, and then you have just a couple of minutes between then and the next session for you to move from one to the other that you have to document that. That's usually not enough time to do that type of documentation, so you end up at the end of the day either documenting after hours or you're hoping and praying for a no-show or a cancellation so that you'll have an hour to go through and catch up all of the paperwork that you had to do from the morning or possibly from the previous day, those types of situations. So in doing that, however, that creates that overwhelmed feeling for your staff and an extra level of stress from your staff's perspective that we don't necessarily need or want. We want to make sure that our staff, are not only healthy, but they have the lowest stress level that they possibly can. And in addition, there's the issue of the accuracy of documentation. The further somebody gets from a session, especially if you're a therapist and you're seeing 4, 5, 6, 7 people over the course of a day, trying to remember the next day or even 2 or 3 days later what happened in that session at 9 o'clock on Monday morning, it's going to become worse and worse. Our memory fades. So if you're documenting in the moment and in that session, then the accuracy of what you're putting in there is going to become higher, and so that helps you as you're moving forward, not only from a clinical perspective, but also from a documentation perspective whenever you're facing the audits and all those fun things that we face as we go forward. From an organizational perspective, we took a look at those items, and when we look at all the different services that we had in terms of outpatient therapy, IPS being employment services, case management, community support, and our medical services, crisis interventions, when you're looking at all those different pieces and all the different services we provide, really that helped us to justify the fact that we needed to focus on concurrent documentation as something that we needed to move forward and utilize. Again, I mentioned that there's always the possibility of a paper interaction, but when you're trying to concurrently document on paper from all of these different programs and all these different services and then combine that into one area so that everybody has the ability to see what everyone else was doing, that's just not possible and practical as you're moving forward in today's day and age. And so the ability to use the electronic health record and to be able to create customized forms that can kind of help you out with that and move this all in the proper direction, that was one of the key pieces that we looked at when we were doing this. And we knew that this was the direction that we were going to have to go to make sure that we kept up with the future and kept up with our future and the directions we wanted to move forward as an agency. So having said that, let's look at the staff benefits here for a moment so that we can have that discussion. And as I mentioned before, the slides you are seeing do come from our training that we provide with our staff members as they come on board as new employees. We had to shrink a little bit naturally because our training is generally 2 to 2.5 hours with our staff members with some actual practice on how they can do this in the field, so to speak. We're not going to be doing any of that today. However, this is a piece that I wanted to point out to you. And we always start out with the comments from the previous staff members that have looked at concurrent documentation and have been utilizing it, and throw those out there so that the people that we're training don't just see, this is Jim's opinion of what's going on from a quality perspective. No, it's actually from your fellow staff members. So they can see when they make the comment that, hey, the quality of the interactions that we have had have increased because of the use of concurrent documentation and because of the use of, these types of services, or that the person's saying, hey, I remember what the client said a lot better, when I'm doing that concurrently than when I'm out in the field providing services. I have to try and remember when I get back to the office. Perhaps I've met with 2 or 3 other people in that timeline, and therefore trying to remember all that information when I get back there is just doesn't work for me. So I can pull the quotes directly from the client as I'm interacting with them and doing that documentation live and doing it, again, in the field so that it's done there and not just back at my office. And also, taking a look, and this is a key piece that we want to make sure that our staff gather and understand, is that you're not doing those notes anymore in a rush between appointments or during your breaks or after work and staying late. As many other organizations, I'm sure, have dealt with this. We've had our master's level staff and other individuals that are staying after hours, trying to get caught up with their documentation to make sure that they've got everything done that needs to get done. We don't have that issue anymore, and my best day in dealing with concurrent documentation was when I had a staff member that ran up and said, this was the best thing that had ever happened to her, that the concurrent documentation changed her life in the sense that she no longer had to worry over the weekends about how she was going to get all the documentation and all of her paperwork done on Monday morning so that she could start the week off clean and clear. She doesn't have to worry about that type of situation anymore. Now she documents in the session, and when she goes into Friday night, she's thinking about her kids, her family, and that type of thing, and doesn't have to worry about what's happened back at the office or what will happen on Monday morning. So that is a very exciting piece from us. And again, that was one of my favorite quotes and one of my favorite moments. From a client perspective, there's also a lot of benefits there in the sense of you have a higher level of engagement from the individual when you're using this level of documentation. In the past we've had situations where people know that we're documenting about them. They know we're doing treatment plans. They know we're doing progress notes. They're well aware that there's information going into a chart somewhere about them. And if you have some individuals that are paranoid, sometimes that can become an issue and can become a barrier clinically to what's going on. And contrary to common belief, most people think that if you have someone that has paranoia that you're working with, that they're going to be, even more paranoid about this and what's going on. And from our perspective, what we've seen is the exact opposite. They say, I know exactly what you're writing about me now. And true, I may not agree with everything that's being said, but at least I know. I'm aware of what's going in, whereas in the past, I was totally unaware of what was going on. And of course, that made me a little paranoid about talking to you. Now I know what's going on, and I know how that's happening or what's happening. And that type of interaction, really helps with that engagement of the individuals and pulling them in fully so that they can really join into that process. In addition, we've had multiple times of, a therapist coming out to us to say, hey, I talked about what was going on. I, was documenting this, and I was telling the person this is what I saw and this is what I felt and this is what I'm putting in the note, only for the individual to turn around and say, no, that is not what I experienced, or that's not what I was saying, or that's not what I was feeling in that moment, and you've really kind of totally missed the mark on that. And that really allows our therapist to kind of jump back in there and say, well, let's talk about that for a second. Where did I miss the mark, and what's really happening? What are you really feeling? And to get a deeper level of connection, if you will, with the person. And that came out of this joint documentation piece, whereas if the therapist was just documenting afterwards on their own, they never would have gotten a hold of those types of discussions and that type of information. So, again, we are really excited about that. There is this thought process, if you will, that's out there that clients will not like this in general, that they'll think, hey, you're just doing paperwork when you're supposed to be interacting with me. And we'll talk a little bit later on about how to work with your staff and train them so that they understand the concept and how to introduce it so the clients understand that it's not just I'm going to send you in a corner while I document, but we're going to work on this together. But also what we've seen and heard and the interactions we've had from the people we've served kind of support the fact that they are involved in this process and they like this process. And we wanted to make sure that we could prove that to our staff members so that they didn't just think that, hey, you're just kind of, thinking about this off the top of your head. And so we utilized a survey, which you can see a couple of results here, and I've got one more slide I'll show you. And this slide really shows the two questions on the individual's happiness, or, if you will, their engagement with the process. And we asked them how helpful it was to them, in the very first question there, and then how involved did they feel on the second question to really, again, get their understanding about what they felt and how they felt about utilizing this new process. And as you can see on the top there, 48%, almost 50%, felt it was very helpful for them to be able to interact and collaboratively document with our staff members what occurred in that session. It allowed them to be able to have that interaction, understand from the therapist's perspective what was going on, and clarify some things, if something wasn't going quite right. An additional 34% thought it was helpful, and so that combination brings you up in the 80% area there that is really in the helpful to very helpful stage. We had lower numbers. 1% had no opinion. Basically, I don't really care. It doesn't really matter. 1% said that it was not helpful, and then 6% said it was very unhelpful. So a grand total of 7% there saying, hey, I don't like this. I'm not really interested in this in any way, shape, or form. And that's a piece that we talk about a little bit later on as well, that we don't try and force this process on our staff members or on our clients. If someone comes in the door and says, absolutely not, I am not interested in this in any way, shape, or form, then we work with our staff members to make time for them to do that documentation at a different space and in a different area. And again, you'll see that here in a minute. But overall, we see that as a positive statement that the mass majority of the folks that we're working with, they find it helpful and they find it something that they want to continue. And also, the involved piece there, 62% saying they felt more involved with this process than they did previously or in their interactions with other agencies. Again, a very positive note from our perspective that it's something that really is helpful and helps the individuals that we serve. Again, my other question, the final question that we'll go over here is, would you want to use this again in the future? 76% saying yes, absolutely. That it's something that they are interested in and they want to make sure that they continue to utilize this as they're going forward. 12% saying they're unsure, so they're on the fence. So it's not an absolute no that they wouldn't want to do it, but they're kind of unsure about it. And in the case of those individuals, we give them a couple more chances, basically. Let's try it out again next time. Let's see what happens. If we still don't like it, if we're still not interested in it, that's fine too. We can move forward and not utilize it. If you decide you do like it because we've tried it and you can see what's being documented and we're working together on this, then by all means we'll continue to use that as we move forward. And so moving on to your agency benefits, of course, this is a piece that we want to emphasize, and this is the piece that my CEO and my CFO are very interested in. When we look at our baseline timelines, you can kind of see there that previously we spent about 11 minutes per session, post-session documenting what was going on, doing treatment plans, doing progress notes, doing that documentation after the session. And when you look at our pilot timelines, we dropped that from 11 to 5. So again, we still have some individuals that are not interested in doing concurrent documentation, and we know that and we acknowledge that, and that's fine. But that decrease in that timeline is significant. So we go from 11 minutes down to 5. We've saved 6 minutes per session. So from my perspective, just as at MHCCI, that's 6 minutes times 25 sessions a week times 45 staff members. I'm looking at 112 hours a week that I have in terms of increased billing and increased productivity on the part of my staff members. So I'm from the state of Illinois. Obviously, everyone has different reimbursement rates and things change across the nation. But from my perspective, that's the potential of over $6,000 a week in increased productivity and increased billing. So that from our perspective, that's critical, especially in today's day and age when budgets are tight and we're facing all sorts of changes in healthcare and in mental health care. That's an important aspect of it as we're moving forward. And to show you how that looked from our pilot perspective, you can kind of see where we implemented the pilot in that first box there. Previously, we were below 100% in terms of our productivity levels with our staff members. We had trouble really in that high 90s. We spent most of our time in the 90 to 95 range, but breaking between 95 and going over 100% was hard for us. That was very difficult. And so as we finished our pilot and did a full rollout, you can see that the numbers jumped above 100 and for the most part, except for holidays, stayed above 100% over the entire time period that we have, on our screen here, which is really about 6 months. So we were very excited about that. Again, it really shows that concurrent documentation can help you from multiple perspectives. From the individual served perspective, they're increasing in terms of their engagement. From a staff perspective, you have decreased stress. And from an agency perspective, you have the possibility of increased productivity there. So multiple areas and multiple ways that we can see benefits from this particular model. Other potential benefits, as I mentioned before, you have increased staff engagement due to lower stress because of out-of-session documentation. We did not track sick time, but I will mention that there are other organizations that have used this model that have told us about a decrease in the sick time used by the staff members, again, related to that lower stress level. So, we are hearing from other organizations that they are seeing those types of outcomes and information as well. Increased accuracy of notes, as I mentioned, you're doing them in the moment, so you know for sure that it's something that's more accurate than something that was documented the next day or 2 or 3 days later. And then a decreased no-show cancel rates due to more engaged individuals that we're working with. So, again, opportunities from all levels there to show positives, in implementing that concurrent documentation model. From our perspective, in terms of implementing the model, we began with training our clinicians. We rolled out a pilot, as I've mentioned before. We had a small group of about 5 to 10 individuals from multiple sites that came together and tried it. We wanted to be able to utilize these individuals as champions as we rolled it out to the remainder of the group. So we saw that as a positive thing. And we trained our clinicians in concurrent documentation. And for the initial rollout, when we were sending it out to everyone, we spent a lot of time interacting with people and making sure that they had everything that they needed in terms of equipment, in terms of their office setup, which I'll show you a little bit later on, and then in terms of all the other items that are out there that you may not necessarily think of. We had thought of laptops for the individuals that are in the community, and we were prepared for that. We had purchased the laptops. One of the things we hadn't thought of, however, was car chargers. Our laptops only stay, fully charged for about 2 hours, and so as we were moving through the process, we realized, oh, hello, we're going to need car chargers so that we can make sure that the laptops are fully charged and able to and are there for the person at the end of the day in the same fashion as they were at the beginning of the day. Tablets are also a consideration. We've just begun at MHCCI using iPads, so I can't necessarily speak to how fabulous they are or not, but so far we like the direction that we're going with them. And then we revise our forms in terms of in the EHR for greater efficiency and to really support concurrent documentation. And I've got a few forms that I'll show you here in a little bit so you can kind of get a feel for that. But that is one of the key structures that I was mentioning earlier, making sure those forms are structured so that your staff members can not only fill them out fairly quickly, but it makes sure that they hit all of the items that are needed for meaningful use and for all of the CPT changes that are coming and all that information that's coming down the road as we move forward. We do want to emphasize the monitor and follow up with clinicians. That's really critical because, obviously we're trained. Everyone gets 2 hours or so of training on how to do this and make sure that their equipment is set up and the room is modeled and is prepared. But still there are some individuals that may have issues in terms of implementing it. They may have problems with their scripts and being comfortable with introducing this to the clients that they're working with, etc. So, we want to make sure we did a follow-up and checked in with people and to make sure that all the training stuck. And if anyone was having issues, problems with implementation, we could either link them to one of those champions that piloted the process or link them to a CIS person, a computer person that could help them out with whatever issues were going on. And, of course, we wanted to make sure we informed the person served and the people that we were working with. For those that have been coming to the agency for some time, obviously this represents a bit of a change in what they were used to. So we made it a point to share with them through newsletters, through our posters that we have in our waiting rooms and in those general areas, and through all of our forms that we pass out. We have multiple areas and multiple ways that we documented this, websites even, so that we could make sure that they understood what was happening and could see all of the changes and the potential benefits of those changes as we were moving forward. And the scripts are critical here, which we will again talk about in the staff implementation discussion, how your staff members, the direct staff that's going to provide the service, really we found that that's the most important part or the most important piece to this discussion was to make sure that they understood and they got that process and implemented it in an appropriate fashion. So from the staff training perspective, we review the reasons for use, the benefits which I've already discussed here to make sure that they understood. We ran through that script creation and use. That was, again, a critical piece to the success to make sure that it was moving forward in an appropriate fashion. Obviously, if I'm someone who's receiving service and the person introduces it to me as, hey, guess what, the boss said I need to do this, and so, I'm going to take a look at this thing that's here and we're going to try it out and see what happens. The people that introduced that way had a lot less success and a lot less client satisfaction with what was going on than someone who followed the scripting models and introduced it in an appropriate fashion. So, scripting and the introduction of the process was really critical. And again, we'll take a look at a couple of scripts here that you can use and really kind of to help people get started with the process. Office setup was also key to make sure that it was important, or to make sure that your structure was set up so that everyone can see the screens and can see what's going on as you're kind of trying to do the collaborative documentation. But also from a safety perspective, you want to make sure that you're making sure everyone in the room is safe as you're moving forward and not just setting up just for CD. We walked through the process and concurrent documentation in action so that people could see this is how it really works in the real world, and people could understand that and move forward with that process. And we reviewed the most common objections. I mentioned a couple of those before, that the staff members tend to tell us that, well, the client's not going to like it, they're going to be paranoid about it, they're not going to be interested in it. We ran through some of those objections and talked about the surveys that we had and really feed that back out to the staff members so they understand what's going on and what's really happening with the individuals that they serve. As part of this, we created both manuals to discuss the use of the scripts and discuss the whole process. So it's not just, again, me standing up there talking to them for 2 hours and they walk out and then there's nothing else. We hope you implement it. Good luck. See you later. We have a manual that you could refer back to so that you could say, oh yeah, this is how I introduce it. Here's a couple of example scripts and things I can use as I'm going forward. And we also videotaped our pilot individuals using the process. And with our new employee orientation that we provide on an ongoing basis, we use those videos to show them what their peers are using and what have been successful in the past in terms of implementing this and working with the patients that they serve. We also talk about the application and how we also built in these trainings and these pieces into other trainings that we had. So when we go back in and when we do our generalized training of how to use the VHR and how to use our clinician's desktop, our electronic health record, we also built in the concurrent documentation pieces into those trainings. So again, it wasn't just me training one time. It was seen as a system perspective on how we utilize the system and how we moved forward. And many of our staff members really, even with the videos, they thought, hey, it would be great if I could take a look at this live, so to speak, if I could take a look at how somebody else does it. And so we allow them to sit in on different sessions and observe others and kind of get a feel for how people do it, especially with the mental health assessment with the MHA, since it is such a big item and since it's, takes a lot of time, we want to make sure that they had that process and the ability to look at that. So moving on into the scripts, the key thing for the script is the very first line. Know how you're going to explain the process before the session comes about. We develop customized scripts for each person so that they can understand and know what they're going to say and be able to utilize it. And after they utilize this a couple of times, then they'll get the idea, and most of the staff members, I think, used them 3 times, sometimes 4, but other than that, they were able to not necessarily memorize it, but have the gist of it and be able to introduce it to individuals without having something in front of them. But the very first couple of times that you're introducing it, the staff really said that the scripts were very helpful, and they liked the idea of being able to develop that and being able to utilize that as they were introducing it. The key piece being focus on the inclusion of the person served. We want to make sure that they understand that I'm not going to sit over here and document while you're in the corner. We're going to work on it together. So again, here's a couple of examples that you can see, introductions that have been created and by some of our individuals as we were moving forward. So, and we pass these out again, and we actually have a larger group of about 10 different sample scripts that we give out depending upon the profession. Someone doing case management versus someone doing therapy versus our doctors, those types of situations. So we make sure that we have a variety of items there that we can pass out to people that they can kind of get an idea of and be able to utilize in their own sessions. In terms of implementation, I kind of mentioned this before, but I'll reiterate, when it comes to assessment and treatment planning, they're doing this in the session. When it comes to your standard progress note for therapy, for case management, we're using that last 5 or 10 minutes to do a summary, to interact with the person and kind of say, this is what I saw in the session, here's your homework for next time. While we're at it, let's kind of document this, let's jot all of this down and put this into this note so that we have it all and can document as we're going forward. One of the key pieces that we wanted to make sure from a staff perspective is that they kind of get the idea that when we're doing this documentation and when we're talking about it, that there are situations when the person may disagree with you and they may not agree with what's going on. Now, if it's a clinical perspective to say this is not what I experienced, that's one thing. But if you're talking substance abuse and you're talking, hey, I need to document in here that we're talking about this issue, and they for some reason are worried about having documentation in their notes about substance abuse or something to that effect, we do talk to the staff about you can't take it out of there, and you can have a discussion with the person to say we need to make sure that we're documenting what's really occurring and what's going on, and I have to make sure that I'm documenting everything that's going on in a general fashion, but we can work on this together. So let's talk about this together, and let's say, how would you document this in our discussions that we had today, and how would you put that into this note and get their feedback? And if they completely ignore substance abuse, then of course we have to readdress that to say, well, we need to kind of plug something in here about this particular item that we discussed. And we work through that with our staff and walk them through some different models and ways of interacting with it and do some role plays with them in the training session to say, okay, let's talk about this. This is the uncomfortable discussion. Let's walk through that. A lot of times, however, what our staff tend to see is as they start doing the documentation and working through it, they actually end up having fewer questions and fewer discussions than what they would anticipate. Their minds in their own heads, they were a little more concerned about items than the reality actually came to be. So as they work forward, it turned out to be a really good thing, practicing it and doing those role plays in the training sessions. Now for group activities, we attempt to do this and attempt to do concurrent documentation during groups. It is much more difficult, and so I can't say that we are 100% the experts on doing it in a group session. We continue to work on that and continue to try and find ways to document. We are excited about some of the specialized progress notes that our EHR is bringing out related to group work. Actually, I believe they're out already. It's just not something that we've gotten to yet, but we do believe that will help out in terms of moving the processes forward, because group work is a little more difficult depending upon the size of what's going on. Now from an Illinois perspective, the last 4 items there in terms of goals, interventions provided, response, etc., these are all the items that we have to make sure that we do in the session. So when we're talking with our staff members and talking about summarizing, we discuss those with them to say, make sure you hit these 4 items. If all else fails, tap into these things and make sure that they're there, and then see what else goes on. So again, we not only talk to them about when they do concurrent documentation, but how they're going to summarize that session and make sure that they have that information out there. One of the other critical pieces here is using the clinical judgment. We, again, have individuals that may not be interested. I mentioned that there are 7% or so that said, I don't like this. And so we say, that's fine. You don't have to work with them with concurrent documentation. Don't necessarily use the very first time they say no as what we're going to say our ultimate answer. We want to make sure that we go ahead and document that and say that we're going to bring it up again next time and go through it again on our next session just to make sure that we have that discussion with them, so that someone may have been having a bad day, but we do want to make sure that they understand that it's a clinical decision. It's up to them, and it's something that we want to make sure that they understand and can address as they're going forward. And in terms of using concurrent documentation in the field, it's the same process in the office as it is in the field. It's just we're doing it on laptops or tablets. But do remind your folks, if you're doing training as we do, that if you're in the field, be mindful of the fact that you have to monitor privacy issues. And obviously you're not going to go and sit in the middle of McDonald's and have a therapy session with somebody and try and document that at the same time. We want to make sure that we're providing that service in an appropriate fashion. In terms of office setup, I mentioned before, greatest flexibility in terms of providing the services and looking at safety. We want to arrange our offices so that everybody can see the screen, so that when we're doing that documentation, we all have input into what's going on. But then set it up so that you can swing the monitor forward towards you, so that afterwards there is still the privacy, just in case if you have a EHR that doesn't allow you to separate out one client versus the others, you have the ability to swing that over and you're still monitoring privacy. And you can kind of see the documentation of what we train our staff with. We have our doors down there on the lower right. We show them where they should be sitting and give them ideas in terms of orienting their desk and the direction the monitor faces, so that they can interact with the individuals and still provide that quality service, but have safety at the same time. There's always discussions about, should you have the desk in the middle and have a clinical break there or not. Everyone's on different pages from that perspective, but nevertheless, as you're setting it up in your own local area, just make sure you do consider the safety aspects at the same time. Revision of our forms was another key piece that we had to take a look at to make sure that we were providing the best quality support to our staff members as they were going forward. So here's an example of one of our previous forms, very basic, very Word format oriented, lots of typing, that type of stuff, even though we had sections in the middle where you could put numbers in. it was reliant upon the person to spend more time using their fingers and typing than using the mouse and clicking through areas. So when we went back and revised, and this is an example of our mental health assessment, you can see that we put in obviously not only a significant number of fields there so they could do tabs and tab through these items, but we made sure that we did a lot of autofills. There are pieces that were in other spots of the EHR that we could grab onto and bring them forward so that our staff members didn't have to re-enter multiple times. And that's a key piece that I think, at least of concurrent documentation, is making sure that if you've got one piece of data, if you will, in the EHR, that you don't enter it 2, 3, 4, 5 times. That extra entry is part of the issues that we face with our staff members, and being able to pull all that out of there and have one piece of data entered one time and then fed to all the other areas, that's critical, and it really helps the staff members as you're moving forward. You also see in the upper right there the copy feature, so that although we don't copy everything, it does copy the items that were there for history so that people can see that, and you don't have to have your staff members continually re-entering the history of the individual. It just simply pulls forward from the previous MHA, and the next time you're doing your mental health assessments with folks, you can document the changes that have occurred between the last assessment and the assessment that's going on right now. And one other piece, you can kind of see that there's a lot of gray space over there on the right-hand side, and that is intentional. We've learned over the course of the years that we want to set up our forms so that there is a right side end limit of 930, and at least from the perspective of the form that we're using, so that it will work and be successful with our iPads. So consider that if you're looking at a laptop, or if you're looking at an iPad or some kind of tablet, the structure of your forms needs to be considered as well, so you can make sure that the staff have the ability to view everything. Here we have an example again of a progress note that we are utilizing. Again, a structured note so that we make sure that the staff members can click on those particular items related to, did they get the height and weight? Was the person a smoker? Were they not a smoker? Did we offer the smoking cessation classes or some sort of documentation as we're moving forward, and making sure that they have that. And then also in the upper right here, you'll notice the command button there so that they can preview their note quickly. And we don't have to have a lot of extra time and space, so to speak, and devoted to, or a lot of time and extra buttons and multiple clicks, so that someone's clicking 3 or 4 or 5 times to get to the point that they print their note out or they view something. We want single clicks so to make their life faster and easier. This is an example of our crisis assessment. This is a new piece. We're just starting to practice concurrent documentation in our ED, and it's something that we are rolling out now. But again, the same concept. We structure our note to make sure that we hit all the items that we want to make sure are on our fields, and including data management and pulling all sorts of data pieces out so that we can make sure that as we're moving forward with our programs and our processes in the future, that we're hitting what we want to hit, and that we have the data to support program structure as we move forward. And our slide here, this is our visual health record. I think Joe kind of mentioned this a little bit. This is the EHR itself. The same concept. As you can see on the top, we're utilizing the red lines. Red, yellow, green is kind of our general process lines, and then blue being historical items, red being items I really want you to pay attention to right now as you're in the session with this person. So that really helps our staff focus in on what's important in the moment, what's important to address in the session, and so they don't forget to do their treatment plan, their assessment. Maybe they don't forget to document the fact that they discuss smoking cessation, those types of things with the person. That way, all the items are addressed, they're there, we talk about them, and we make sure we have that as we go through each of our sessions. And informing person served, just kind of moving on with that piece, I'll let you know that scripts are the key piece as we're working through this. That's the main rollout piece. There are signs at the desk, there are notations on forms, there's articles, but scripting for your staff members, the main person that's going to provide that service, that is critical, and that is the most important piece of your rollout. So make sure you spend time with your staff members talking to them about the scripts, helping them work out their own scripts, and helping them to understand the benefits that they have and the benefits as the staff members, the benefits to the clients. That's just, I can't emphasize enough how critical that is in terms of the rollout and making sure that the process is successful as you work forward. Do make sure you resolve any laptop or tablet issues first. The catch we saw with them is if you roll them out and you have problems with them, people stop using them. Even if you fix it later on, that can become an issue because then you have to re-engage someone into the use of a laptop or a tablet. So try and address all those issues up front as much as you can. Revise your forms, as I mentioned, and have that extra support and retrain staff members as they need to. There are some people that get it the very first time. There are some people that don't, and so we just want to make sure that you have that support there for those folks. Credit-wise, I want to throw it out. We're happy to do presentations. We love being able to interact, but we're not the only people that are doing this. There are a lot of other organizations from around the country that have implemented this process. We used a consultant in our initial pilot. We used MTM services, with Scott Lloyd, and they kind of helped us out and helped us get on the road with the process. And so I throw that out there that obviously that there's other consultants out there. Echo itself, they've not only developed their own structured notes and their own forms that can assist with concurrent documentation, but their staff members, helped us as well when we're talking about concurrent documentation, saying, hey, we got to roll this out with the ED, and we're going to be utilizing this process in the ERs. This is new for us. Our staff are concerned about it. They've helped us with different items and suggestions and ways that we can roll it out in a positive fashion that really make sure that our staff are supported and make sure that they are hitting all of the different items that they want to hit. So having said that, I will throw that out for questions and see where we need to go from here.
Okay. Thank you very much, Jim, for that discussion. There are quite a few questions here, actually, and you've done a very good job of touching on the basics in terms of the most important parts of the process and touching on several of the forms to change. There were a couple of questions about the interaction with group when you're using a, if you can possibly do concurrent documentation with a group. Is there anything to add to that or anything, what is it about a group that makes it perhaps more difficult to do this?
Well, the group part is not only the time interaction because you're documenting, within the group itself, and you're trying to get that information, but you have multiple people. Smaller groups are better. Obviously, if you're doing a group with 5 to 7 people, you have fewer people that you're going to have to get their feedback from. Larger groups are much more difficult. In Illinois, we max out at 15. That would be really difficult from my perspective to do a group with 15 people and try and get feedback from each person about what needs to be in the note. However, having said that, it is a group format, so the group can help you document that, and they can design what's occurring with each individual or with each group. And so the group itself can say, okay, this is what occurred at the group, this is what we covered, this is what was happening, this is how we feel that we were able to help each other and have those discussions there. And then generally we do a round robin to say, what did you individually feel? How do you feel that you benefited from this group, and how did things go for you, and do you feel that you made any progress on your issues? And as those individuals share that feedback, we would be documenting that, quickly, naturally, as fast as our little fingers can fly across the keyboard, but documenting as much as we can so we could get the individual feedback from each person. Again, some people will say, well, but then you have privacy issues, but the reality is in that group, you are providing that same level of feedback, so we're not stepping outside of what would be addressed in the group anyway. And therefore the privacy really is not a concern or an issue there. It's more along the lines of just making sure that we can grab on to the data and the information that's occurring there.
Okay, good behavioral healthcare manager's question. When you talked about going over 100% productivity, was that over 100% of a target? That one graph, you kind of had things going above and below 100%. Was the center line there a target?
It was a target, and not to throw out too many percentages, but what we look for is 25 hours of service per staff member, assuming full-time, of course, and we expect that to be provided on an ongoing basis. And so that's what we were looking at in terms of our target and being able to hit 100% or going above that.
Okay, good. And for people that went over it, someone asked, do you find your staff now wanting more money when they get over the target?
We have not had that issue, no. I'm not saying it won't come up tomorrow, but we haven't had that issue yet. We are, however, looking at the possibilities of, is there any way that we could try and incent individuals to try and go above the target? You know, naturally, you've got people that are just a little below, people are at, people that are a little above. So we're looking at the possibility to say, is there a way that we can incent those that are below or right at the target to move up a notch or two? But in terms of the question itself, no, we have not had individuals asking for additional money.
Okay. There's a couple of questions regarding people working in nursing homes or people working with elderly clients. Let's see. Assessment and therapy is provided in individual homes. What would you suggest to aid in implementation of concurrent documentation while providing outreach therapy for people either in nursing homes or at right in their own homes?
Well, we do have, if I understand the question there, we do have case managers that are going out into the community and providing services in individuals' homes and in the community itself. And our process there was to utilize the laptops, and now we're just starting to transition into tablets to provide them the ability to interact with folks, and our training concerns of making sure that, you know, again, privacy is still critical there, and making sure you're not violating anyone's privacy, but they still provide that service. So within the home, they might provide the case management service, but then afterwards, at the end, when they're summarizing and saying, hey, this is what occurred and this is what the homework I'd like you to do for next time, that type of thing, they would go ahead and pull out the laptop or the tablet and do the documentation right there.
Sure.
I can't say we go into nursing homes per se, but we do have individuals that provide the service on the job site through our employment counselors, and they do the same concept, but of course, you know, to watch privacy, they're pulling people back into either the break room or the manager's office or some more private area to have their discussions, but nevertheless, they are still providing that service and still doing that documentation with the person served.
Now, when you're out in the field working, do you use like air cards or something like that? Are you trying to keep a sort of a real-time link with the system, or, you know, do you record the stuff later?
We do use air cards so that we have that real-time connection. And I know there are other products out there. Joe may even be able to talk about the VHR Traveler that they have that is not directly connected but downloads when the staff member gets back. We have chosen the air cards because our IT folks at the hospital, we are connected with a health system, and our IT folks prefer the air cards, and also the ability to make sure that what's going on in that particular moment is fed back live, so that if the doctor logs into somebody's chart to see what's going on, they can see what happened 15 minutes ago with the patient, and they have the most up-to-date information that's available.
Okay. Joe, do you have anything to add to that?
Only that, as Jim said, there are different approaches. We have customers that are using air cards and devices like that to connect up and do community-based work. Other folks have had challenges with that, even in urban areas, having good signals. And, of course, there is some financial overhead there. And as a result, we've introduced a product that does allow using our full EHR in a disconnected manner, not connected to the internet, and it's a synchronized sort of solution where you kind of take a data set on the road, do your job, and then resync to the main database later, and we call that Traveler. So there are different approaches there to doing the work.
Okay, and presumably that Traveler thing would work if you lost a connection, which sometimes happened, right? If you were working and wirelessly.
Correct. Yeah, Traveler actually requires no connection to the internet at all to use the electronic health record.
Okay. Okay. Good. And there were any number of questions about working with children, whether it's in play therapy or clinical settings or whatever. What's your experience working with children? Is this an effective approach, or is it a needed approach with kids?
It is both effective and needed, in my opinion. One of the original quotes, I think it was the first one I had in the slide deck, was from a child therapist. And that particular person really threw out the idea that they saw a greater interaction from their kids when they were doing that documentation and collaboratively documenting as well. And she was also the person that told me that it really changed her life. She was the person that came forward and said this is the greatest thing that ever happened to her since sliced bread. So I think that really kind of supports the fact that it can work with kids, and we use kids, adults, through the whole spectrum.
Hey, Dennis, if I can jump on that a little bit.
Sure.
We've seen that in other customers as well, that, children generally enjoy technology. They want their iPod. They want to play games on television. Having someone turn a screen to them is pretty compelling, not to mention one of the primary kids' issues is alienation and not being listened to. When you see their words on the screen, that's a pretty strong affirmation that someone is invested in them, and that's been powerful for people, I think.
Okay, good. You know what, folks? There are more questions than we have minutes left, but we do record all the questions from the session and pass them along, and I think you can expect a reply at an appropriate time. Let me wrap up things by saying many thanks to our speakers, and let me give you just the last couple of final instructions about getting your CE credits for today. At this time, please click on the green CE certificate button located at the bottom of your screen. This CE button should generate your CE certificate for this event. Please be sure to save the certificate to your hard drive before you print it. Also note that you have to have viewed today's entire program to qualify for a CE certificate. And if you have any other questions or issues regarding CE certificates, please click on the Contact CE Help Desk button at the bottom of your screen. That will send an email to our Vendome Group help desk. You could also reach this help desk by going to by mailing to webinars@vendomegrp.com. As a registrant for today's event, you will receive an email within the next 24 hours which will provide on-demand access to an archived recording of the presentation. That'll last for up to 1 year from today's date. You can share the presentation with colleagues. And if you enjoyed today's program, we invite you to view a list of upcoming webinars and to join in our community discussion through our Facebook and LinkedIn groups through the links featured in today's resource list. Finally, I want to thank Jim Wilkerson and Joe Viget once again for an interesting, excellent presentation. Also, thanks to the ECHO Group for making the program possible. And thanks to all of you for participating today. We hope you'll join us in the future for another behavioral health care webinar. That concludes today's presentation. Many thanks.